Thank you very much and good morning to everybody. Uh, Due to some restrictions from the hospital administration, I cannot come to Dubai. But anyway, I can be with you all the time, and very soon we will be do a live conference. So, topic of today: what are the factors affecting the outcome for Okay, so the topic of today is factor affecting outcome for the low birth weight babies. The the topic is very vast, but I try to cover it in this giving time. So the prematurity and survival is always the hot topic for all of us, and it has a lot of morbidity and mortality. But what we have to do in a in a very meticulous way, we can do and we can help those babies. So the early deliveries, the death can be the more than 40% of, and 40% of infant morbidity. This is the very latest data from Abu Dhabi, and it is published from the Zayed University in International Journal of Environment in 2020 in Public Health. And the rate of the preterm and the low birth weight were found to be high, it's 6.3%, but it still is lower than other Middle Eastern countries. But so they suggest that the current study highlights the need for further interventional research to tackle these public health issues, such as reducing the high CS rate. And this is one of the problem, that we have a high CS rate, and it can affect the outcome of those babies. The morbidity in singletons without anomalies is also high, and it is not only the very micro preemies, it's also in the moderate preemie and the late preterm. And as you can see here, they can also get intubated, and they have the other morbidity, and the p-values are significant in that. Now, look, come to this part, the cognitive ability. This is the very important data to look into it. 24 weekers, and this is 32 weekers, and this is the adjusted IQ. So even the 33 weeker barely reaches the 95 IQ, adjusted IQ, and adjusted controlled mean is 100. We have to think about it. So we can give a baby who can be the good human being, or the outcome of that as an adult, and he can be important member of our social society. So, but if we have just save the baby and then forget about what is the cognitive ability, then it's a big problem. So that's why this is just a very recent data which is presented in Hot Topics. I was in Hot Topics, and it just finished yesterday, Thursday evening. And this is the data from the Germany, and they are doing it. This is the Sweden, Germany, Austria, different European country. So very micro preemie, the many of those centers are giving just a comfort care. And the reason is that we have to understand that just the survival is not the only important thing. There are many other things which we can have to look into it. So I have to admit that whenever I saw a picture in a magazine and newspaper, 22 weeker, 450-gram survivor, and there's a big hype on that, miracle baby. I mean, these are just hype around nothing, and it not give a right situation that what is happening to the baby. And why I'm saying that, because the Satyan, Dr. Satyan made this very important slide. The factor influencing the adult outcomes for the preterms, not only the pregnancy and fetal health, the environment, the socioeconomic status of the family, the education, the pollution, the maternal and the paternal factors, the preterm and the birth and the consequences, the many of those can affect the adult outcome. We're not looking just to survive this baby, but to look the healthy adult outcome of those babies. So having said that, uh, we have to admit that these babies cannot be dealt with very good outcome in any center. So this is the study which is take 1976 to 2010, and they found out that the mortality risk increased for preterm infant not born hospital with a level 3 NICU. So not all the NICUs are able to have those babies, and this is again published in 2018 in OBGYN, and they also suggest that morbidity, mortality, composite outcome showed that VLBW infant delivered at high levels NICU had improved outcome compared with those delivered at low ones. So we have to understand that everything related to those babies are important. Now, there is a lot of prenatal intervention, and this thing we will go through one by one. So let's start that the baby is not delivered yet, and the mother is with you, and you are expecting the baby to deliver. The most important thing nowadays, which can affect the outcome of those babies, is antenatal steroid. Please ask your OBGYN to give antenatal steroids. We are giving antenatal steroid up to 38 weeks of gestation. If the mother come and just deliver, you cannot do much, but if you have, most of the time you have that much time to give antenatal steroid. And there's a lot of data, but look at the death, IVH grade 3 and PVL by ANS exposure. Here the ANS antenatal steroid is in here, no antenatal steroid. So any age group, it is much better outcome. Same with the IVH grade 3, exposure to ANS is much better outcome. Not only the IVH, but also the respiratory support, the composite meat after the betamethasone is much improved, and it is statistically significant as compared to the placebo. Severe respiratory morbidity is also improved in the antenatal steroids. So this is the two major issue outcomes I just told you, but there are many ways antenatal steroids help. So this is just the meta-analysis as published in 2016, and it favors the corticosteroids in the help of the severe respiratory distress syndrome. Another thing which you can do, you should give to all those ladies and all those mother antenatal magnesium sulfate. And this is the neuroprotective effect in utero exposure to magnesium sulfate. It has antioxidant effect, it blockage of glutamate activated calcium channel, prevention of large blood pressure fluctuation. There are two major trials. One is analysis, and the one is trial, PREMAC trial, which is about 600 women, less than 33 weeks, and they have a very good, strong trend toward protective effect of magnesium against CP or death. Then the Cochrane review have the meta-analysis, which is 5 trials, including 6,000 infants, and they also found that there's a significant reduction at risk of any CP and moderate to severe CP. Number need to treat is 63, but magnesium sulfate is not that expensive, so it is okay. Now, the intrapartum interventions are also very important. We have to look into it, into many things. First is, as I mentioned about the C-section, look at this data, which is published in 2009. This is the 50%, this is the respiratory morbidity, the 50% is the highest. This is the elective C-section. Look at the 34, 35, 36 week, the elective C-section, the respiratory morbidity is high as compared to the planned vaginal delivery. And it goes, and it is the same at about 39 weeks. But due to some reason, which is not explained very well, in 41 weeks, it start again increasing. Now come to the neonatal factors. So the most important thing nowadays, when the baby delivered, we heard about delayed cord clamping. Delayed cord clamping has a lot of effect. Please do not mix with the delayed cord clamping with the umbilical cord milking. Again, this is very recently, the day before, 2 days ago, the ILCOR member presented this data into the hot topics, and they found it out the same which we know, that delayed cord clamping has a benefits as compared to the umbilical cord milking in a very premature babies. And it is not only the benefits which is written here, there are many. This is only just the tip of the iceberg, is the many other benefits. But I will show you one data which is get my attention too much, because we are using this technology of the NIRS in my previous place of the work. The delayed cord clamping, 60-second to 90-second improve the tissue oxygenation index. This is the brain tissue oxygenation, and by the help of this technology, you can see how much is the saturation. So look at this, at 4-hour, 24-hour, and 72-hour, it is higher than as compared to the control group. So the delayed cord clamping, you should apply it in your centers. The ETT sectioning or the sectionings at any time of any babies, if there is no consensus on that, and if the baby don't need a section, do not do the section. There is no such thing called routine section. And why I'm saying that, because in the full-term babies, look at that, the minutes to at 86% saturation and minute to 92% saturation in section babies and section babies, it was delayed. It is delayed by almost 3 minutes, and 92% is almost 4 to 5 minutes. So look at this. So why we are doing it? If we don't need it, we shouldn't do it. And that's why there's another data in 2013 that if you just wipe the mouth and nose, it is just as good as you are sectioning and without any delay in the saturation of the babies. Now, the very important thing, that mechanical ventilation. We should avoid mechanical ventilation as much as possible. The intubation should give the stress, procedure, higher intrathoracic pressure, reduced venous return, and suctioning. Hemodynamic changes can happen. We just discussed about that. So that's why there are many studies done on that. One is by our friend Dr. Hani Ali in 2012. Is a retrospective study. Is found that the IVF was independently associated with lower birth weight mechanical ventilation and the cumulative duration of the mechanical ventilation. So not only the respiratory problem, the neurological outcome can be affected by the ventilation. The other study, which is 2018 in the Alberta group from the Canada, they published that high tidal volume delivery during mask PPV at birth was associated with brain injury. Strategies to limit the tidal volume delivery during the mask PPV should be used to prevent high tidal volume delivery. So this is the thing, that the gentle, as much as gentle you are with the baby, that is the outcome is good. So this is not a brainer that CPAP, we are all using it in the delivery room, even the very smallest baby, we start with that. This is the Cochrane review in 2016 and go in the favor of CPAP. So the death of the BPD is in the favor of the CPAP, is published in the neonatal research also. But the problem is this one. I always showed this study, this article provided by Peter Davis, one of our friend, and they did a very comprehensive studies about 12,000 babies. And what they found it out, in a very micro preemies, 25 to 28 weeks, the 43% is failure rate of the CPAP, and 29 to 32 weeks, it is a bigger babies, 21% the failure rate. And the incidence of the death of the BPD increase in those babies. So how to tackle that problem? So my response to all those evidence is that yes, we started with the CPAP. Yes, we rescue the babies. I have a very low threshold. So as soon as we reach 6 centimeter or anything above 30% of oxygen on those small babies, we give the surfactant. So is this right to, yes, if you go through all the evidence, there is no time to go through it, but it is right. And the CPAP is not the magic bullet for the BPD. We should, as we see just in the previous slide. So the searches still continue. The CPAP and the surfactant without the ETT, yes. So what we are doing is the LISA technique, and I will show you something on that. So now you deliver the baby, you put the baby on the CPAP, but the baby is not doing well. So we have to give surfactant because it's a surfactant deficient baby. Surfactant not only help in the respiratory problems, but also help in the neuro development and the IVH, as you can see here. So the prophylaxis versus rescue, this is the controversy, is that you should give the surfactant prophylactically to all those babies, or you do the rescue. The problem is the literature. The pre-CPAP literature showed the prophylaxis is better than rescue. The CPAP era, which is late 90s and the early 2000, it showed decreased death or BPD if it's stabilized on CPAP than rescue surfactant. So the rescue surfactant is recommended, but we are having a very, very low threshold. As soon as we think that the baby needed, we give the surfactant, we remove the catheter, and we put the baby again on the CPAP or NIPPV. So how to give the surfactant? This is the ensure technique. You intubate, you remove the surfactant, laryngeal mask administration. This is gaining attention in hot topics. The data is presented. But we are, as you said, using the LISA technique, and the death and the BPD, as you can see, are not crossing the line of one confidence interval as compared to here with ensure technique. And not only that, there's a ranking probability of strategies published in 2016. The least, if you see the death or the chronic lung disease, the LISA ranking #1 in favor of decreasing both. And if you take the BPD alone, again, the LISA technique is #1. So this is about the surfactant, how you do that. Which surfactant? There's a lot of debate. There's a one meta-analysis is published in Cochrane, is the favor in the poractin or porcine surfactant, but still the debate is going on. Whatever you have, if you are doing and you are doing other things in the right direction, I think the outcome can be good. Caffeine, you all know, we will start the caffeine at the day one, okay? As soon as the possible, you should start, but we are not starting in the delivery room. There is no data to suggest that. So start the caffeine as much as possible, and there is no data that we should start in the delivery room. Caffeine is really a very good medicine in helping those babies. Another controversy is about the transfusion, that the transfusion has the risk of the independent risk for many things. So here the first, the controversies between the RBC transfusion and the NECs, which is not really anything related to it. And the data suggests not. But among the very low birth weights in RBC transfusion, for subsequent developing severe IVH, yes, it is can be the independent course. So this is the latest guideline given yesterday by Dr. Harish Kirpalani, that how you, when you transfuse the babies. So it is cardiopulmonary disease, if 12 gram, 36%. If it is on oxygen dependent, then it's 30%, otherwise 7. So although they said in their debate that there is no difference between the conservative and the liberal transfusion data, but they like the more restrictive transfusion policies as compared to the liberal. Postnatal steroids has always a lot of controversies, but there are some data which suggests that if you give the postnatal steroid after 7 days of life, it can help the outcome of the babies in the right directions. Now, the comfort measures, the pain, stress, swallowing, all these can help this baby. So the quiet, dark environment help in the neuro development of those babies. So appropriate respiratory support, avoid rapid IV flushes, UA, UVC sampling. This is called the IVH bundle of the care. And we had this bundle in my previous place of the work, and it's very easy to follow. You just have to take that you are following it in all those babies. And I cannot share the data right now because our publication in reducing IVH in preterm baby less than 30 weeks of gestation in NICU level 3, a bundle of the care, it is in public, it is already in publication. So it is come in 2-3 months from now. So I will share that data. It really help in reducing the IVH of the babies. Midline head positioning, we should do that for the first 72 hours, and the data suggests in favor of it. Now, the other cares are very important, maintaining the temperature. Many times you will see if you take the temperature of those micropreemies, they are hypothermic. So please try to maintain the temperature 36.5 to 37.5. The fluid management is big controversy. Somebody starts 70, somebody start 90, but this is the recommendation, 70 to 90 ml per kg per day. Restrictive fluid reduce PDA, NAC, and BPD. Delaying sodium supplementation to day 3 improves the outcome. And early feeds, as just Lamia talk about that with the EBM. This is another important outcome, or another important guideline from the consensus guideline 2019, and also the AAP. Please do not try to treat the numbers. So the treatment of hypotension is only, I put it in red and the bold, recommended when it is confirmed by the evidence of poor tissue perfusion such as oliguria, acidosis, and poor capillary return, rather than purely on numerical values. And the reason is that the dopamine has a vasoconstrictor effect, and when the baby is on the transition and the pulmonary vessels try to relax, and if you start the dopamine, it can give the vasoconstriction in the pulmonary vasculature and can give you the PPH, and which can affect the your treatment and everything. So please do not go through the gestational age and the mean blood pressure, and you start just to see if the baby is perfused very well, if it's oliguria or not, if it is poor capillary return, and then only. This is again the controversy. The PDA, we are not treating that often, but when we have to treat, we use the paracetamol. Hemoglobin, I already discussed about it. Now, the impact of choosing bovine products. Now, this is a very important thing, that so not only the NEC, the formula feeding is not appropriate. We have to encourage breast feeding. And of course, beyond NEC prevention, there is a lot of other things which we have to look into it. The breast milk is the best. It decreases the ROP, it decreases the mortality, decreases the BPD, and the neurodevelopmental outcome is also great. Now, this is again another friend of ours, is Dr. Joseph New, publishes this in 2020, that how you prevent NEC in those small babies. So decrease risk of NEC. Antenatal steroid is one of them. If you have to close, the ibuprofen has much in favor of the not to give NEC as compared to the indomethacin, but we are using acetaminophen, which is more less side effect as compared to both of these. The very important thing, that lower saturation can give you the increased chances of NEC as compared to the higher. So we are putting 90 to 95%, and these are some data on that. The important thing to show here is the slow versus delayed or the early. So that's the thing, that you shouldn't slow the feeding. You give 20 to 25 ml per kg per day, and increase progressively, which goes in favor of better outcome as compared to the delayed feeding. Human milk fortified, because the recommended dose, as Lamia just mentioned, is 4, but the premature milk has only 2.5. So that's the problem. That's the problem here is going on. So we have to fortify the milk. And as you can see here, not only the protein, but also the other micronutrients. If you give the human milk alone in those premature, the chances of having osteopenia, prematurity, and other problems are high as compared to the fortified milk. You can fortify it with the powder, but now the human milk fortifier is also available. So this will not take too much time. Now this is the preterm birth anticipated. You give antenatal steroids, ask them. What we are doing is accordingly to get a better outcome is that if the baby is more than 27 weeks and breathing, we start with nasal CPAP, 30% oxygen, and titrate accordingly. And if this baby will not tolerate, then of course we intubate, give LISA technique, and give the surfactant. If the baby is less than 27 weeks, we have a very low threshold to do the LISA and give the surfactant. As I told you, prophylactic work is rescue, the failure of the CPAP. In those micropremies, the chances of having more failure are more here as compared to the international data. We put the saturation limit 90 to 96% for less than 1500 gram or the 32 weeks. Hemodynamic stability, check the urine output, check the perfusion, check the lactic acid by your blood gas, and do not jump onto the pressors or the dopamine and dobutamine unless until you really need that. Had in the midline for the 72 hours. So we have this IVH care bundle, which I just showed you. It is very effective in reducing the rate of the IVH. We strictly follow the golden rule. We have to complete all the major things like UAC, UVC, if the baby needed antibiotics within first hour of the life. Caffeine, as I told you, is the very important to start as early as possible. Not only the respiratory problem, it helps in the neurodevelopmental outcome of those babies. Cranial ultrasound we do in the day number of life of 3. Try to have as much as non-invasive monitoring. Whether you have NIRS or not is not a problem, but you try to do as much as non-invasive monitoring. Do not use the blood gases too much, because when you take the blood quickly and give back that blood quickly, it can affect the autoregulation, cerebral autoregulation of those babies. So if you don't need, there is no need to do the very frequent blood gases in these babies. You can just monitor by the non-invasive monitoring, pulse oximetry, and the carbon dioxide or the carbon dioxide measurement, entitled carbon dioxide measurement. TPN we just discussed. Rightly, we start with the 3 gram per kg per day amino acid, 1 gram per kg per day. The intralipid 80 ml to 90 ml per kg per day. The fluid we start day 1, which we call vanilla TPN. Early feeding, as soon as we have the breast milk, we are not waiting for more than 48 hours for breast milk. Remember this, and we just discussed in the hot topic with Dr. Joseph New, the worst thing is the empty gut, then is the formula, then is the donor milk, and of course the best is the breast milk. So this is the thing, the breast milk is the best, then the donor milk, then the formula, and the worst is to keep the baby, keep the gut empty. So that's why start as soon as possible the feed. We remove the UAC, UVC less than 7 days, and if the baby needed for some reason, we put the PIC line. Of course, the minimum handling, there is no such thing called routine sectioning or routine this thing, routine measurement. If the baby needs it, we touch the baby, otherwise there is no this thing. And of course, the kangaroo care. So that's all I have to talk about. But in the last, I will give you this thing that all those micro preemie babies are saying that I'm not just a small baby, I am a preterm baby, I am a unique baby with unique problems. So we have to handle them uniquely. Thanks a lot.